Hello everyone, welcome to this BioWatch special from the ASCO meeting 2024. We're here today with Professor Tony Mok. Professor Tony Mok is the chair of the clinical oncology of the Chinese University in Hong Kong. A person that is very well known for his work in treatment of lung cancer, especially in targeted therapy. Welcome and thank you, Professor.
Thank you.
As everybody knows, Dr. Mok was the first one to publish the benefit of starting anti-EGFR treatment with the IPAS data, and that's been now 15 years now from the publication of the IPAS. And from then now, we evolved a lot with the osimertinib data, with the FLORA study, and last year we had the FLORA 2 data and also the Mariposa data. Now that we have about 6 months, 8 months from those trials, how do you see the treatment of first-line patients with EGFR mutation metastatic disease?
Right, I think it's important, by the way, this is the 20th anniversary since the discovery of the EGFR mutation, and a lot had happened since then. Now, I think FLORA had given us the fundamental that this is one agent that can penetrate the brain, give you long progression-free survival. So people add on to it. So there's no doubt FLORA2 is positive with further improvement of the progression-free survival, including the patient with or without the brain met. And also in the Mariposa study, with the combination of the amivantamab and the dasatinib, which is a Korean-made third-generation drug, that seem to also have the improvement in progression-free survival. However, we have to ask one basic question. Should all patients receive the combination or the single agent? Now, obviously, we have very good quality of life with the single agent osimertinib. But once you get on combination, that you add on the toxicity. Yes, chemotherapy may be some and tolerable, but on the other hand, for the Mariposa, the toxicity seems to be more significant. So you have to really balance. So the first logic is to identify the high-risk group. And then this year in ASCO, they have this subgroup analysis of all the high-risk group, including TP53, patient with brain met, liver met, and also had the baseline cfDNA positive EGFR mutation, and then also the 9 weeks positive. Now, all those was demonstrated that there is a difference between the combination of amivantamab and dasatinib over osimertinib. However, only prognostic. It's not predictive because that you see the difference whether you have the liver met or you don't have the liver met, you have the brain met, no brain met, is actually the separation is there. So it's no longer so-called the predictive. Only the one with the 9 weeks positive, then there seems to be a bit different in the hazard ratio. So potentially, but we need further validation study to use the post-treatment of so-called EGFR plasma DNA to decide whether we want to add on the combination or not.
And also here in ASCO, we had a very interesting study, despite being a small study, the study presented by the University of Texas, I think, with just 29 patients, but patients with mutations that underwent SABR, like stereotactic radiotherapy, and that induced a PFS, a really nice PFS of over 30 months, about 3 years. What do you think about this strategy? You think this is something that we can think about, especially on the patients with the lower risk, with the less volume of disease?
Right. So first of all, I think the SABR was not given right in the beginning, but rather after treatment, in the patient had residual disease, they provide the SABR, because otherwise that
after 6 months, right?
Yeah, after 6 months, they provide the SABR. So in other words, if you got a disease that is still resistant, not actually behaving well after 6 months, probably a local treatment is appropriate. So in a sense, is that it is not a randomized study, but it gives us a signal that potentially we have a better control or the one that is actually not responding well. So this is not the only study. There are other smaller studies, some from China, some from Hong Kong, that also show that addition of SABR to the patient who have residual disease. In the China study, actually almost like 5 years ago, there was actually less than 5 sites they provide the radiation that seem also have the improvement of the progression free. So I think the concept is sound, but not proven by a randomized study.
And the last thing is that I want to talk about is with the data that we just saw from LAURA, with the use of osimertinib in patients with stage 3 that was treated with chemoradiation. Do you think we are ready to start treating patients with stage 3 disease as metastatic disease, as a systemic disease, and we should start treating those patients for life?
Right. I mean, so there's a two good signal from the LAURA. Is one is that most of stage 3 disease probably have a metastatic disease. However, they are actually microscopic metastatic disease. Should we treat the microscopic disease, stage 4 disease, same as the gross stage 4 disease? That is a bit debatable. However, one important fact of the LAURA is the fact that they give osimertinib indefinitely. And then so therefore they have median progression-free survival of 39 months. So which is outrageously good. So in a way, when we go home, the next patient who come in, I have no doubt that I would take the LAURA approach. But then the only other question is that, what can we really give it forever? Or should we give it a shorter time and just monitor? So those questions remain to be explored in the future.
Maybe the question is not for whom to give, but maybe who can we stop?
Exactly, and then how long can we stop it for? Can we use so-called circulating DNA to guide us for the future treatment? Maybe so treat it for 2 years, negative, give them a holiday, monitor, positive, and then start treating again. So those are kind of give us a new so-called insight on how best to manage this kind of so-called the presence of microscopic metastatic disease.
Yeah, and this MRD data that we saw from Adara is something that I was thinking, it feels like we're starting treating EGFR patients just like the hematologists treat myeloid leukemia.
Absolutely.
Just dosing MRD and starting
Right.
and stopping
So
treatment.
from the now that you mentioned that the MRD from the Adora data is actually very interesting. There are 5 cases that are positive before starting, and then they give them the adjuvant osimertinib, and then 4 out of 5 disappear. But then after 3 years, they stopped osimertinib, and 4 out of 5 actually have a positive again within 12 months. So now to give you the question is that maybe those are the patients you should treat it longer.
Yeah. All right. Thank you so much, Professor Mok, for being here with us, and thank you for all your work you do to benefit patients with lung cancer.
And thank you for the invitation. Thank you.